I went to podiatry school. Most of our courses are the same, but where they do, you know, OBGYN and psychiatry, I had more foot specialized classes that I took. Then residency, my first year of residency was pretty similar to an intern year of a medical doctor. I did that at the Cleveland Clinic, rotated through endocrinology, rheumatology, ER, that kind of stuff. The last 2 years I was mostly specialized in just foot and ankle. Forefoot, rear foot, reconstructive, you know, basically 3-year residency for a foot and ankle doctor is about the maximum there is. You can go on to do a fellowship. I didn't do that. I felt like I had enough training during residency. So where, you know, a medical doctor, they do their intern year and then they usually specialize. You know, ortho, they usually go for 5 years. You know, I don't, we could go to ER doctors like 3 years. So does that kind of clear it up a little bit? Mm-hmm. Okay. This question is for chronic ingrown toenails, is it best to keep the nail short or long? And I would say if you have a chronic ingrown toenail, just have a permanent nail procedure done because they are like the key to life. So that is where we just can take out that edge of nail that gives you an issue, put a little chemical in there to kill the matrix, and then it doesn't come back. Yes?
What happens if it does come back?
You just have it done again. There's an 89% chance success rate that it won't come back. Okay. I can say this from personal experience. They are the key to life. Okay? What diagnosis will I or do I send to physical therapy? I send a lot to therapy, but I feel like I haven't sent as much to therapy here as I have in my past because for some reason I think that people are tougher here and they get better quicker. So I send a lot of like tendonitis, plantar fasciitis if it gets to that point. My post-op patients, I've just done a couple Achilles tendon ruptures and FHL tendon transfers that will be coming your way. Sometimes after an ankle fracture, if the patient feels they need it. So the question is, what is one thing you wish athletes knew about running? And I don't really think I wish that they knew anything. I can't, you know, say, oh, your joints are going to break. I'm a runner. You know, I don't run as much as I should, but I enjoy running. I'm not going to be like, oh, it's like terrible for you. And those minimalist shoes, I feel like are, you know, I started to read that book. I just couldn't get into it. But they really kind of, do you know what I'm talking about? Like the 5-finger, right? That's what you're talking about? Yeah. So those shoes, I think, are meant to, like, teach you how to run properly. But, like, we're not all built the same. We don't weigh the same. Like, we're not all perfect, you know, built. So I don't really think those shoes are the best thing. I would rather go for more cushion. So, like, I usually veer people towards like Hoka's where the sole is like 2 inches thick and it's super shock absorbent. And that's my, I don't know if that answers your question. I just have seen tons of stress fractures with those minimalist shoes. So I don't, or plantar fasciitis, I just don't think they have any support for like, especially long distance. So I don't know. You're a special person if you can hold up a Does date of injury, age, and sex of patient matter in regards to how quickly to get a fracture patient in for an appointment? Me personally, if anybody, I mean, children heal the fastest, so they're like, it's super important to get them in right now. But honestly, I prefer to see any fracture patient right now. You know, if my schedule is booked, I'm happy to add them on wherever we need to because, you know, if it's a non-displaced fracture and they've already been treated in a boot, then yeah, it's probably not as important, but I don't expect, you know, you guys making the appointments to know, oh, it's non-displaced, this is safe. I'd rather just see them right away. Is there really anything that can be done for a fractured toe? Typically, just put them in a post-op shoe, they feel better, but I can't say that that's always the case. There are plenty of toes that I've had to reduce in the office to put them back in place. There's plenty of toes that I've ended up pinning, and that's more in like the pediatric population than in the adult world. But I mean, they usually heal just fine with nothing, but you know, that one time we say, oh, you're fine, tape it up, they probably need this, you know, reduced. So I think there's a place for them. There's a place for accommodative custom orthotics with diabetics because they're custom fit and they sort of offload the prominent areas of their foot so they don't get a wound. I think they're important for like people with plantar fibromas, which is kind of like a soft tissue mass on the plantar aspect of the foot. Those are, it's not really the best idea to take those out because they have a really high reoccurrence rate. So sometimes a custom orthotic can help offload that so that they don't have as much pain or inflammation. And then why do corns hurt so bad and what can be done to help decrease the pain? You probably have a corn because you have like shear friction, and that's what your body does to help protect itself, is it builds a callus or a corn. Occasionally one will kind of grow into a pore, and that feels like you're walking on a rock. Sometimes it's due to a bony prominence, sometimes it's a new pair of shoes, you just walk differently, but that's why they hurt so bad. And usually if you can get them out and just sort of offload them, you do better. But just your basic callus, your body's it's just the way you walk, and your body's just trying to protect itself. So does that help? And decrease the pain, cut it off. Thomas Stone that thing off.
Like
over the counter. I've had more luck with like the Linko inserts and the UCOs. The UCOs are good if somebody has like a fallen arch, because they don't, my rule of thumb is if I can put 2 fingers of pressure on it and it has a little bit of give, then that's good. If it flattens like a pancake, it's not doing anything for you. But if it's so rigid that it has no give, you probably won't tolerate it. So, and there's a point too for custom orthotics in kids, I think, when we really have to functionally correct them. But again, that's when they come in with pain, not just because they're flat-footed.
Other than like the inserts that you can get for plantar, I'm not sure
Fasciitis.
Pronounce it, fasciitis. Is there anything else much that you can do to
For
help
plantar
alleviate that?
fasciitis?
Yeah.
Yes, you can. Stretching is the key to plantar fasciitis. That's usually you get plantar fasciitis. So, do you guys know what plantar fasciitis is? It's the band, like a ligamentous band that runs on the bottom of your foot. So this is your foot. It's on the bottom, and it's sort of like a pulley system with the Achilles tendon that runs up the back of your leg. So you can't really get this ligamentous band to stretch, but you can stretch your calf muscle. So if you can get that stretched out, it gives a little bit of laxity down here, so this isn't so tight and getting inflamed. So typically, stretching and icing to plantar fasciitis is the most important thing beyond any insert or steroid injection.
What causes toe fungus in your toenail?
That's probably $1 million question. Usually like you're immunosuppressed. It happens a lot in immunosuppressed patients. Sometimes, it just happens. Your sneakers your shoes are a good place for fungus to live because it's dark and it's moist. So, you can, but usually there's something else going on, but people do get it. But sometimes if it's just a toenail, it's probably not a fungus. It's probably because of micro trauma in your shoes.
Like your shoes are too tight?
I'm not so much too tight, but maybe that toe just sort of hits in your shoes as you walk. Sometimes people get it in their 5th toe just because that toe is constantly rubbing on the outside of their shoe.
What about athlete's foot? Constantly coming back. Like
You asked for your shoes.
What if you get brand new shoes?
You think so?
I'm just kidding. No, my question is as far as like over the counter for that or prescription, what's
Lamisil over the counter is good. The topical, I think Lotrozone cream is a prescription that's good. And then spray your shoes with Lysol or some sort of silver agent.
And how often should you change your shoes?
Well, I don't know, but you should spray them consistently for 2 weeks.
Okay. Do you have a favorite surgery that you like to do?
No, not really.
Did you like the more complex stuff?
I like tendon ruptures, tears. I like doing tendon transfers. I like ankle fractures. Not really. I don't mind a bunion though, or a hammer. I don't mind that. So not really.
And how has bunion surgery changed over the my mom. She's petrified of having bunion surgery because her sister had it years ago, was in pain for
I don't know why everybody has this concept that like that's the worst surgery ever. I don't know, you know, my whole thought is I've had bunion surgery myself, and I stayed on my butt for a week with my foot elevated, and I really didn't take any pain meds. So I just think like the maybe old school way, we didn't say like stay down. You just had foot surgery. The foot is the most dependent area on the body, and when it swells, there's only so much room for swelling to go, and it hurts. So I don't know if like maybe in the past we just didn't tell them stay off of it, like keep it elevated. You're you know, until at least that skin is healed. You know, I don't know, because we still kind of use some of those old techniques. In fact, I think maybe we're even a little bit more invasive now with, you know, before maybe they would just go in and sort of knock off the bump, where now we sort of make a cut in the bone and slide it over. But I just don't really have a lot of people complaining of pain after that. And I never really, I'm sure that it can happen, but.
Do you just cut the bunion or do you realign?
I realign. You kind of take like that bump off and then you make a cut in the bone and sort of shift it over.
What is a bunion?
A bunion is like an imbalance of the soft tissues. Do you know what it looks like? Like I need a foot model, but basically it's where the big toe is like this. You know, if this was my left big toe, you kind of get this bump on the inside there. And it's usually like genetic. Could be due to shoe gear, typically more genetic. But it's really an imbalance of the intermuscular system inside your foot. There's a lot of layers and a lot of intrinsic musculature. So it's usually an imbalance of that is why it happens. So.
Are you a believer in bone growth stimulators?
Yes.
Do you use them a lot with your fractures?
I do, especially like the 20-minute ones because they're approved for acute fractures. Usually most insurances will cover it. So if they cover it, why not? I think it's helped. I've seen them even help like with non-unions that are 6 months old. So yeah, I like the 20-minute ones because who's gonna wear that thing for 8 hours? That's my opinion.
What's your protocol for your Achilles tendon repairs or ruptures? I mean, does everybody get surgery usually, or do you do none?
I do conservative treatment. I think I was more of I was trained in both. We did a lot of conservative as much as we did surgical. And I would say probably the last 4 years of practicing, I basically, you know, laid it all out here. Here's the risk to conservative and here's the risk to surgical intervention. You know, what do you want to do? You know, and I think the biggest thing with conservative treatment is, you know, you might not be as strong as you once were.
Is there a age where you would always do
Surgical or conservative?
Yeah.
No, I mean, there's a lot more literature out there that supports doing it, treating them conservatively and even the younger population. I mean, the old school thought was, you know, if you're, I don't want to put a number out there, but, you know, past a certain age or maybe you have more of a sedentary lifestyle, we lean more towards conservative treatment. But there's been a lot more research out there now that says, hey, you know, maybe these heal just fine, and even the younger population. And I think I've seen it in several cases where it does heal just fine.
You don't see fusions, do you?
I see fusions.
Oh, you do?
Mm-hmm. What do you mean by that, though?
Well, like, do you do the fusion?
I do. Like, I do first MPJ fusions.
Okay.
I've done midfoot fusions. I don't prefer to do ankle fusions or subtalar joint fusions.
Okay.
But, you know, like I said, if you're asking in regards to, like, scheduling a patient, then sometimes, you know, patients aren't, like, ready for a fusion right now.
Yeah.
And they need more, you know, conservative treatment prior to that. And then they also are like, well, who do I go to?
Yeah.
So I feel like there's still a place for them to see me if they, you know, need that preoperative conservative care, and then maybe just who they should go to.
I do have a question.
Okay.
Because I scheduled this surgery and you did 2 different kinds of bunionectomies on that patient Tuesday.
Okay. What is that?
Well, because it was the same foot, so I guess I just wasn't. I didn't
So regular bunion is of the big toe, and a tailor's bunion is of the fifth toe.
What is neuroma?
Neuroma, like in the long bones of your foot, there is a nerve, and it sort of branches out and supplies each side of the foot. There's one in each inner space. So sometimes they can get just inflamed, sometimes you can get some scar tissue build up around them, but people complain of a lot of forefoot pain, like a bunched up sock under their foot or just a burning pain. So that would usually be the nerve.
What made you want to become a podiatrist?
Well, you probably saw my biography, but no, I had bunion surgery when I was 13. So it just kind of turned me on to medicine, and I worked I worked with a plastic surgeon, I worked with tons of orthopedic surgeons, PAs. I guess at the end of the day, I sort of went back to podiatry. I just felt like it was a better lifestyle. As most orthos take a ton of call, and that's not really what I wanted to do. So it still could, I still had sports medicine in there and trauma, and I just felt like it was a better lifestyle.
What do you do in your free time when you're not playing the role of the physician?
Ride horses. Like if it doesn't revolve around a horse, I'm not doing it. Yeah, that I don't know if it's my obsession or my passion, but that's pretty much my life. I have 4 horses that I will live and die with, and then I usually snag one or two here and there that need help or need fixed, or and just try to make them the best that they can be, and then kind of line them up with who they line up with. But I'm pretty protective over them, especially if I put time into them, so I like to make sure it's a good fit. So.
What do you do with the horses?
I do money shooting and reining and trail, cattle work. Yeah, I don't know. Pretty much if I find a horse I like, I try to figure out what they do and then try to do it, which it doesn't always look very pretty, but I try. Yeah. I haven't done any jumping yet. I'm a little afraid of heights. I don't think that day's ever going to happen, but yeah. So pretty much anything, if you can do it on a horse, I'm in.
What breed do you prefer?
What breed? Quarter horse. Yeah, those Arabian. I'm just kidding. I have to get my dig done on Dr.